Ahlan Biku. Today we're going to start our three-part lectures on the orbit and eye. So let's begin. The orbit, the bony orbit, where the eye lies, the globe lies, the eyeball, is formed by contributions from the surrounding bones. It's pyramidal in shape with like it's thrown on its back, so the apex points backwards, posteromedial, and the base actually opens onto the face. It has a roof and floor and medial and lateral walls. The roof is formed largely by contribution from the frontal bone and completed posteriorly by the lesser wing of the sphenoid. As you can see, this is the frontal part, and back posterior, this is the part belongs to the lesser wing of sphenoid. The roof separates the orbit from the anterior cranial cavity. And features in the roof, you'll find two depressions. An anterolateral depression is called the lacrimal fossa for the lacrimal gland, and anteromedial depression called the trochlear fovea for the fibrous trochlea, fixed here for the tendon of the superior oblique muscle. So remember the features: two depressions in the roof. The anteromedial is the trochlear fovea, and anterolateral is the lacrimal fossa. The medial wall, look at the medial wall from front backwards. See, it starts with a process from the maxilla, the maxillary process, orbital process of the maxilla. Okay, then you go back, you'll find this bone posteriorly. It's the lacrimal bone, an individual bone by itself, lacrimal bone, that articulates posteriorly with orbital plate of the ethmoid bone. See, this is the orbital plate of the ethmoid. And behind the ethmoid, a small portion by the upper end of the palatine bone. See, it reaches up here to form part of the medial wall of the orbit. And then by sphenoid. So we have the maxilla, we have the lacrimal bone, we have the perpendicular or orbital plate of the, sorry, not the perpendicular, the orbital plate of the ethmoid, and part of the palatine bone and the sphenoid. This is the medial wall. The medial wall is largely formed by the ethmoid, and it's fragile, very fragile, because what lies behind the wall? Exactly, the ethmoid air cells, the bubbles. So that's why the wall is very thin, the medial wall. Okay, now look anteriorly. There is a fossa formed here. It has an anterior crest formed by the process of the maxilla, and a posterior crest formed by the lacrimal bone. These are multiple choice questions. Which crest is formed by what? So the anterior is formed by the maxilla, and the posterior is formed by the lacrimal. And the common mistake here, that the fossa formed is for many think that it's for the lacrimal gland. No, it's in the lacrimal, for the lacrimal sac. Just a sac that collects the tears produced by the lacrimal gland in the upper lateral surface of the orbit, upper lateral area of the orbit. So don't get confused. This is a very common mistake. Okay, what else features you can find in the medial wall? See this suture. This is called the frontoethmoid suture. This suture. In the suture you'll find, see, this is the posterior ethmoid foramen. Somewhere anterior you'll find the anterior ethmoid foramen. Okay, so these are for the anterior and posterior ethmoid branches, vessels and nerves. We studied these when we studied the paranasal air sinuses, especially the ethmoid group. And we talked about the blood and nerve supply of the sinuses. We mentioned the anterior and posterior ethmoid of the ophthalmic, either artery or ophthalmic nerve. So this is the features in the medial wall. It's easily broken by the way. The fractures of the floor and medial wall are the commonest. What else? The floor is formed in most of it by the plate of the maxilla and slight contribution from the zygomatic bone from the lateral side, and it has a groove. See this groove? This is the infraorbital groove for the infraorbital nerve and vessels before they sink down in a canal, the infraorbital canal that opens to the outside through the infraorbital foramen. This is the infraorbital foramen. This is the groove apparent here for the infraorbital nerve and vessels. And see, the groove does not continue to the very end because it's turning into a canal deep in the bone that will open in the infraorbital foramen. Now in the floor is the inferior orbital fissure. Okay, this is the inferior orbital fissure. Actually, it's on the lateral side of the floor and between it and the lateral wall. The lateral wall is formed anteriorly by the zygomatic bone, and posteriorly by the greater wing of the sphenoid. As you can see here, this is the suture between the two, and the superior orbital fissure, the one you see here, is between the greater and lesser wings of sphenoid, and this is a very common question. The superior orbital fissure between the lesser and greater wings of the sphenoids. As I told you before, the fractures are common for the floor and the medial wall, and if medial wall is involved and you made an x-ray, you will find air in the orbit in radiographs because of the fracture of the ethmoid air cells, ethmoid labyrinth. Okay, this is for the floor lateral wall and fractures. This concludes the bony orbit. Of course, it's the bony orbit is lined by periosteum from the inside, and that's continuous to the outside, and we will use this information now. Now for the eyelids. Of course, we have two eyelids, upper eyelid, lower eyelid, superior and inferior eyelids, and between them is the palpebral fissure, the eye opening. Now, if you take a section in the eyelid, you will find the layers of the eyelid is as follows, starting with the skin, then a layer of subcutaneous tissue. The subcutaneous tissue is responsible for the edema that forms in the eye, in the eyelids after injury. Extensive edema, actually, because it's a very loose layer here, the subcutaneous connective tissue. It's considered the hypodermis of the skin. Then comes the muscle layer. This is a cut section of the circular muscle fibers of the orbicularis oculi. This is the palpebral part. See, this is a cut section of the palpebral part of the orbicularis oculi. So skin, subcutaneous tissue, muscle layer, then comes the orbital septum. See? This is the orbital septum. The orbital septum ends here by uniting with the tendon of the levator palpebrae superioris, as you can see here. This is the orbital septum. It's an extension of the periosteum of the orbit. What else? Behind the orbital septum level, there is the tarsus. This is the tarsus, a layer of dense connective tissue, but as you can see here, embedded in the tarsus are numerous special type of glands, mucus glands, that are in the tarsus and near the hair follicles as well of the eyelashes, near the hair follicles and in the tarsus. Then after the tarsus, you will get the mucus lining, which is the conjunctiva, and conjunctiva reflects upwards in a fornix, as we will talk about soon. Okay, so don't forget the skin, subcutaneous tissue, muscle layer, the septum, the tarsus, and then the conjunctiva or conjunctiva that reflects backwards to after lining the eyelid backwards in a fornix to be reflected on the sclera of the eyeball. Since we mentioned the orbicularis oculi muscle, we talked about it before. Let me remind you that it has three parts: the orbital part, which is the large continuous part outside the orbit, and that arises from the medial palpebral ligament but is not attached to the lateral palpebral ligament, as I told you before, for the purse string action or tight closure of the eye. And then we have the palpebral part, which is in the eyelid, as you can see here, part of the eyelid, and this is the one that's attached to both ligaments, the medial palpebral and lateral palpebral ligaments, and the tiny lacrimal part that passes behind the lacrimal sac. And as we learned, when it contracts, it pulls on the sac, dilates it, so it sucks tears through the puncti and canaliculi to fill up the sac, okay? Then to be drained through the nasolacrimal duct to the inferior meatus of the nose. This is about the orbicularis oculi. Of course, you remember the nerve supply by the temporal and zygomatic branches of the facial nerve. Now, what else? Within the eyelids, we mentioned the orbital septum. The orbital septum is an extension of the outer and inner layers of the periosteum that lines the orbit. The inner layer is the one that lines the orbit. The outer layer is continuous outwards. So as if you have taken a fold from the margins of the orbit, from the periosteum, and inserted it in the upper eyelid and the tendon of the aponeurosis of the levator palpebrae superioris and tarsus, and in the lower eyelid you inserted it into the inferior tarsus. Okay, this is the orbital septum. Of course, it has to be pierced by structures going to the outside. See, like the supratrochlear, supraorbital, infratrochlear nerve and vessels must be pierced by these structures to supply the outside areas. Okay, now the tarsus is a dense layer of connective tissue, plates thrown into plates, upper plate in the upper eyelid and lower plate in the lower eyelid. They are called the tarsal plates, and them too are attached to the medial palpebral ligament and the lateral palpebral ligament. See, the lateral is to the margin of the orbit, the medial is to anterior lacrimal crest. Remember this. The palpebral ligament medial is to the anterior crest, anterior lacrimal crest, because we will encounter a check ligament which is attached to the posterior lacrimal crest. There is a difference between the two structures. Okay, so this is about the tarsus. The levator palpebrae superioris muscle is one of the extraocular muscles, and it's the most superior of them all. See, when we made a hole in the roof of the orbit, the first muscle to appear is the levator palpebrae superioris. It takes from the back of the roof of the orbit and fans anteriorly as you can see here, and then ends by forming an aponeurosis. That's to be attached to the anterior surface of the superior tarsus. Attaches on the surface of the superior tarsus, while beneath this muscle, as the belly of this muscle, is a different type of muscle fibers, smooth muscle layer, deep to the levator palpebrae superioris, considered to be part of it, but it's smooth muscle layer. It's called the superior tarsal muscle. The superior tarsal muscle attaches to the edge of the tarsal plate. So the superficial muscle is the levator palpebrae superioris to the anterior surface of the tarsal plate, and beneath it the superior tarsal muscle to the edge of the superior tarsus. Now, of course, from its direction, the action of the levator palpebrae superioris, as the name says, it will elevate the upper eyelid, so opening the eye. So expect when paralyzed, there will be drooping of the eyelids called ptosis. Ptosis, the P is silent, ptosis. The nerve supply of the muscle is from the superior division of the oculomotor nerve, and for the smooth muscle part, which is the superior tarsal muscle, is supplied by sympathetic. Remember this, sympathetic supply. Sympathetic supply, okay? Okay. Now, going deeper to the eyelids, you will find a mucous membrane layer. It's called the conjunctiva or conjunctiva. It lines the eyelids. This is the palpebral part, and reflected as a fornix to the ocular surface. This is called the ocular part. So it has palpebral and ocular parts on the sclera, and ends at the level or at the corneo. This is the cornea, corneoscleral junction. It ends at the corneoscleral junction, and surrounds the eye is the reflection of the conjunctiva, which is called the fornix. So you can divide the fornix, regions of the fornix, into superior fornix, inferior fornix, medial and lateral fornices, which are all, of course, continuous. It's the circumference of the eyeball. Okay, now in the superior fornix opens the numerous ductules of the lacrimal gland. Remember this, the superior fornix receives the openings of the ducts of the lacrimal gland. We will talk about the lacrimal gland now. Now, the glands in the eyelids, we said that many of them in the substance of the tarsal plates as tarsal glands, and the remainder is at the hair follicles of the eyelashes. Okay, now inflammation of the ones in the tarsal plates produce a condition called chalazion. See, it's infection at the inside of the eyelid, at the inside of the eyelid. Okay, of course it's apparent from the outside, not because of the inflammatory reaction, the redness and hotness and etc. But inflammation of the one of the glands at the hair follicles is called a stye. This is stye. See, it's at the edge of the eyelid, not the inside of the eyelid. It's important to differentiate between the two conditions, the stye and chalazion. Okay, the chalazion may need surgical intervention, by the way, if it's chronic, if it became chronic. Okay, now for the supply, the blood supply of the eyelids it comes from the ophthalmic, supraorbital, supratrochlear branches, lacrimal branches for the upper eyelid. For the lower eyelid, from the infraorbital vessels. Infraorbital comes from the maxillary. Okay, we have infratrochlear here that from the ophthalmic to supply the medial canthus. The lacrimal supplies the lateral canthus. The angular artery of the facial takes a share, and even the superficial temporal and the transverse facial may supply the eyelid area. Okay, and lymphatics go to the submandibular lymph nodes. Now the innervation. Sensory by the supraorbital, supratrochlear, lacrimal, all from the ophthalmic. The upper eyelid is taken up by the ophthalmic, by the way, and the lower eyelid it is taken up by the infraorbital nerve, which is branch of the maxillary. So the sensory from the upper eyelid is through ophthalmic, and the sensory from the lower eyelid is through maxillary nerve, through its infraorbital branch. Remember this. The motor, motor to the orbicularis oculi, we said it's the facial, and paralysis of in Bell's palsy, the patient won't be able to close the eye. Means that the inferior eyelid will sag, and the tears will accumulate in the inferior eyelid and spill, causing a spillage of tears. Okay, and of course, if continues without the care of the eye, there will be corneal ulcerations because it's always exposed to the outer environment. On the contrary, if paralysis of the injury of the oculomotor nerve results in complete ptosis of the eye, means unable to elevate the upper eyelid, okay, because the levator palpebrae superioris will be non-functional. If there is a lesion, sympathetic lesion, like in Horner's syndrome, for example, ptosis, meiosis, anhydrosis, there will be constant partial ptosis because the levator palpebrae superioris is spared. The only part damaged is the superior tarsal muscle, okay, which is weaker than the levator palpebrae superioris. So there will be a constant partial ptosis. Okay, this is regarding the blood and nerve supply of the eyelids. Let's switch to another subject, which is the lacrimal apparatus. The lacrimal apparatus simply formed from the gland, this is the production factory, the gland, and the drainage system, which are the puncti, small tiny holes that will lead you canaliculi, small tiny canals, a couple of puncti and a couple of canaliculi that will lead you to a lacrimal sac, and the lacrimal sac will empty through the nasolacrimal duct in the inferior meatus of the nose. Okay? The lacrimal gland is in the superolateral region of the orbit and makes an impression on the bone called the lacrimal fossa. But remember, the lacrimal gland behaves like the submandibular gland in a way that it encloses the lateral edge of the levator palpebrae superioris, turns around it. Actually, the aponeurosis of the levator palpebrae superioris will divide the gland into upper and lower parts, and both parts are connected by ductules through the aponeurosis of the levator palpebrae superioris. Remember this. Okay, and now it opens by numerous ductules through the superior fornix of the conjunctiva, and blinking brings the tears down and medial, brings the tears down and medial towards the lacrimal sac system. The tears form a lake here in the inferior eyelid, and the puncti suck the tears through the dilation of the lacrimal sac by the lacrimal part of the orbicularis oculi. Whenever it contracts by blinking, it pulls on the sac. This is the sac here. pulls on the sac, dilates, and through the puncti you can see one here and one here. This is the superior punctum, this is the inferior punctum, the canaliculus, superior canaliculus, inferior canaliculus, and unite to open into the sac. And the sac sucks the tears from the lake of tears and then opens through the nasolacrimal duct. This is the mucous membrane lining the nasolacrimal duct exposed. The walls are broken here. Okay, this is the nasolacrimal duct going to the inferior meatus of in the lateral wall of the nose. We studied this before. Okay, it's very beautifully dissected in this specimen. Okay, this is the lacrimal apparatus. It's a simple and a good topic for an essay question especially. Okay, the innervation of the gland, we said each gland, every gland has its parasympathetic and sympathetic supply. The parasympathetic supply of the gland, remember, the source is facial through the greater petrosal. The greater petrosal that arises from the geniculate ganglion of the facial and emerges through the petrous temporal bone. You know the story of the greater petrosal, passes under the internal carotid artery and receives a branch, the deep petrosal, and to go through the pterygoid canal as the nerve of the pterygoid canal or Vidian nerve, and then to the pterygopalatine ganglia, which is the ganglia, parasympathetic ganglia for the gland. But it's important to know how the parasympathetic precisely reaches the gland. We said we arrived to the maxillary nerve, so it will be distributed with the maxillary nerve branches. One of the branches is the zygomatic, see? The zygomatic branch. And the zygomatic branch will give zygomaticotemporal and zygomaticofacial. Zygomaticofacial will open on the face at front on the zygoma. And the zygomaticotemporal, as you know, will continue upwards and supplies part of the temporal fossa. But see this connection here in the lateral wall of the orbit? This connection, these are the parasympathetic fibers jumping from the zygomaticotemporal, because the zygomaticotemporal will continue to a different destination. So it jumps off the zygomaticotemporal branch in the lateral, under the mucosa of the lateral wall of the orbit to join the lacrimal nerve of the ophthalmic and then to the lacrimal gland. You should know this. You should know this path, how the parasympathetic supply reaches the lacrimal gland. Okay? Okay, the sympathetic is, the source of it is the superior cervical sympathetic ganglia that received from T1 and then distributed plexus around the internal carotid artery, which gave the deep petrosal nerve, and you know the rest of the story, that it will be distributed with the branches of the maxillary nerve after becoming the nerve of the pterygoid canal. The vessels by the ophthalmic artery and drained by the ophthalmic vein. Okay? Okay, this is regarding the lacrimal apparatus subject. Now, if you take a look at the orbit, let's talk about the gateways or the foramina and fissures in the orbit. The optic canal is in the apex, and we said the orbit is like a pyramid thrown on its back. The apex is posteromedial. So the optic canal is posteromedial in the orbit and formed by the body and lesser wing of the sphenoid bone. This is the optic canal. The optic canal has the optic nerve in it with the ophthalmic artery infralateral to it, and then the artery will, when enters the orbit, will cross over the nerve from lateral to medial. Okay? We will study this when we get into the orbit. The superior orbital fissure is between the lesser wing of the sphenoid and the greater wing of the sphenoid, and structures passing in it is the lacrimal, the frontal, trochlear. You should learn them in sequence, in order, from lateral to medial. Lacrimal, frontal, trochlear, superior division of oculomotor, nasociliary, inferior division of oculomotor, then abducens and ophthalmic vein. Abducens actually rather is not the most medial, rather than being inferior to them in the superior orbital fissure with the inferior ophthalmic vein. There is a phrase to help you remember the sequence: live free to see no insult at all with an O, okay? To learn the structures passing in the superior orbital fissure. And as you can see here, this is the trochlear nerve, this is the ophthalmic nerve with its supraorbital and frontal branches, this is the lacrimal nerve, okay, and the abducens nerve, okay. And as you can see here, this is the ophthalmic artery arising from the internal carotid, and it's infralateral to the optic nerve in the canal, as you can see here, okay. Then crosses later from lateral to medial, as I told you before. Okay, the inferior orbital fissure, still talking about the fissures and foramina, is between actually the orbital plate of the maxilla and the lateral wall, and structures passing in the inferior orbital fissure, the maxillary nerve, its zygomatic branch, the infraorbital nerve and vessels, okay, and the communication with the pterygoid venous plexus. And remember that we mentioned the inferior orbital fissure when we studied the pterygopalatine fossa, and we mentioned the inferior orbital fissure when we studied the infratemporal fossa. Actually, and in the middle part of the inferior orbital fissure, it opens into the infratemporal fossa, while the posterior part of the fissure, because it's going posteromedial, as you can see here, so it's in a more medial level than the middle part, so the posterior part opens into the pterygopalatine fossa, as we studied in the last lecture. Now you are oriented. This is the inferior orbital fissure. Other openings are the anterior and posterior ethmoidal foramina, the nasolacrimal duct that starts in the floor of the lacrimal fossa and goes to through the nasolacrimal, through the lateral wall of nose, and opens in the inferior meatus in the lateral wall of the nose. And this is all about the fissures and foramina of the orbit. Every one is unique, and it is easy to study and remember. Now, going deeper for the fascia of the eye, there's a special covering of the eye other than the sclera. I'm not talking about the fibrous coat of the eyeball. This is the fibrous coat of the eyeball, which is the sclera. No, surrounding the sclera, enclosing the sclera, is another sheath. It's called the orbit sheath, or the eye sheath, the fascia of the eye, or Tennant's capsule, and it encloses the eye and attached posteriorly around the exit of the optic nerve and anterior to the corneoscleral junction. See, this is the corneoscleral junction, and this is the fascia open here, cut open. It has a smooth, shiny under surface between it and the potential space between it and the sclera. It's called the subtenon's space because the fascia is called Tennant's capsule. See, medially it forms the medial check ligament. This is the medial check ligament attached to a tubercle, orbital tubercle on the medial wall of the orbit, and a lateral check ligament attached to the medial check ligament attaches to the posterior crest, lacrimal crest, formed by the lacrimal bone, and the lateral is attached to a tubercle on the lateral wall of the orbit. And see, I told you I drew your attention to the fact that the medial palpebral ligament is attached to the anterior lacrimal crest, while the medial check ligament is attached to the posterior lacrimal crest. Now, between the two check ligaments, the lower part of the sheath thickens to form the suspensory ligament of the globe or the eyeball. See, the eyeball is not thrown on the inferior wall of the orbit. No, it hangs in the middle by means of the suspensory ligament that is part of the Tenon's capsule and stretches between the medial and lateral check ligaments. Now, the other fascia in the eye, rather than the fascia that covers the eyeball, it's the fascia that lines the orbit, and actually it is the periosteum that lines the orbit, and it's called periorbita. The periorbita is the periosteum that lines the walls of the orbit. And remember, we said about the lining periosteum that together with the outer periosteum, they send a fold extension in the upper and lower eyelids to form the orbital septum. Remember these. Okay, so the periorbita and the facial sheath of the eye, and the medial and lateral check ligaments. So that would be all for today, and see you in the next lecture. Thank you very much for watching.